All right, I see we are at the top of the hour. So, welcome to the final day of the 2025 CAW conference. Here at Stroudwater, we focus exclusively on rural and community hospitals from Maine to Hawaii and Alaska. Our team of former CEOs, clinicians, financial leaders works all across all areas of performance, financial, operational, clinical, quality, and strategic to help hospitals like yours address today's challenges and build a stronger future. We believe deeply in the importance of keeping care local, and we're proud to support the hospitals that make that possible in every corner of the country. Our final day of programming centers on improving hospital performance and building durable provider strategy. In our first session, we have Eric Schell, Wade Gallen, and Megan Weber that speaking to us on improving rural hospital financial performance. Assess, align, accelerate. This session will walk through how independent assessments can surface hidden opportunities for operational and financial improvement, and how rural hospitals can apply targeted recommendations to drive measurable impact. So, with that, Wade, I'm going to hand it over to you and let you get started with the presentation. Looking forward to it.
Appreciate it, Amy. And it's good to be with you all today. We're looking forward to talking a little bit more about rural hospital performance improvement. So what we're gonna do during this session is really give you a bit of a window into how we view rural hospital performance improvement, and then kind of go through a process that has been used. Eric, I got to ask, how many hospitals do you think at this point we've been doing this for? Yeah.
We'll put that number at several hundred.
To be conservative, yeah. You got the accountant brain on there to get the conservative numbers in there. But so this will really, again, just be a little bit of a window into our approach here at Stroudwater. And then we're going to get the awesome opportunity to hear from Megan Weber, who is a CEO at Scotland County Hospital. So we're looking forward to really hearing more about her insight into what they've done at Scotland County. And to start off, really just want to frame, our approach here to performance improvement. When we're doing performance improvement work for rural hospitals, we want to stick to a few key principles, right? We want to be grounded in data. So any performance improvement plan for rural hospitals really needs to be grounded in the information that's available. It's one of the keys. One of the keys to success, as Eric is going to talk about here in a minute, we have to be improvement focused, right? Or a growth mentality and abundance mindset. Again, Eric will touch on this a little bit more. And through many performance improvement engagements, we've really learned a lot, and we're excited to chat a little bit more about some of those learnings. But want to emphasize having a strong performance improvement plan and strategy can be a great boon for growth at a rural hospital. When we're thinking about development of detailed performance improvement plans, what we're really thinking about are things that are going to be high impact. So they're going to have a benefit to the community. They're going to have a benefit to the bottom line in many cases. They need to be meaningful, right? So they're targeted towards each hospital, right? You've seen one rural hospital, you've seen one rural hospital. There's no, cookie cutter approach to this. And so we really need to develop performance improvement plans. And when we think about developing those, they have to be community focused and, again, individualized for each hospital. And they also have to be actionable. I think that's one of the key lessons that we've really learned is when we're putting together performance improvement plans, we have to have something actionable. We've got some processes we'll talk about in a little bit that are related to that. And really, there are three keys to rural hospital success. Again, Eric is going to share and expound upon these in a bit more detail in a minute. But really, we have three kind of fundamentals that we've seen, and that's an abundance mindset, fundamental understanding of hospital economics. So really understanding how changes in, say, volumes would impact our financial performance. And then a measurement culture, right? Going back to that, being grounded in data, we have to make sure that in the absence of a measurement culture, it can be very easy for things outside of data to kind of rule our decision making. And so we want to have that true measurement culture as we're thinking about performance improvement. Just a real brief intro to kind of the process that we've used. I know that there's a number of different approaches out there, but when we're conducting performance improvement work, generally what happens is there's an introductory call. So we'll get a sense, get a lay of the land, if you will, really try and understand what are some of the key issues on this person's mind or in that community. We follow that up with data analysis, right? Again, going back to a measurement culture and being data driven, we take, everything from, financial information, quality improvement information, volume information, provider information, really trying to get as much information as we can to then fuel a series of on-site discussions. We found, and I'm sure Eric could comment on this more, but we found that really being on site gives you a great feel for an organization, and you really get a sense of the community, get a sense of what is truly important, and can develop those relationships, which is a great part of the performance improvement process. So, again, from our process, when we're doing those on-site interviews, we then develop a report, and it outlines a few different things. One, we've got current operational status or current operations for a rural hospital. And then we always want to be considering what's rural hospital best practice. And so really mapping out current operations compared to those best practices is a real key to any performance improvement plan, I would say. And so then there are some identified opportunities as well as recommendations that can be, again, actionable, things that we can really put into practice, and preferably in a quick time frame. And so, once all that information has been developed and a report has been put together, you can have, we traditionally do a report presentation where we outline all of the things that we've noted. And then the on-site action planning, which we have a section devoted to this a little bit later, is where we really start to do the fun work of putting together an actionable plan based upon where a hospital currently is, and looking at identified opportunities, trying to figure out what's the most meaningful in this particular case. We use a very specific process for that. So again, we'll touch on that a bit later. But this is an overview, again, of just our process to performance improvement work. But it's all really rooted, again, in some of those 3 keys to success that we noted on the earlier slide. And so as we go through, I'm going to let Eric take over here, and he's going to really talk through some of those keys to success.
Great, thanks, Wade. Good afternoon, many. Good morning, many more. Thanks for joining us today. My name is Eric Schell, and I'm a principal and chair of Stroudwater Associates. And I'm joining you from the Delta Sky Club at DCA National Airport. So when the process that Wade just laid out is about something, it's a product, or not product, it's a process that we call a strategic financial operational assessment. And in part of delivering this, what we like to say to organizations, and this is rooted in years and years and years of experience, is that a strategic financial operational assessment, when we go in to look at the performance of a rural hospital, there's 3 ways that you can improve the bottom line. The first way is to figure out a way to grow volume, and growing volume. When 90% of our costs are fixed or step fixed costs, growing volume contributes a 90% contribution margin. So growing volume is the tide that lifts all boats. And so that's our focus number 1. Our focus number 2 is getting paid better for what we're currently providing and what we can be providing in the future. For the critical access hospitals, it's your cost report. It's all organizations, revenue cycle. How do we improve the revenue cycle? The third area of improvement is to figure out a way to cut expenses. And in our experience, that has been a recommendation, of the couple hundred or even maybe 300 strategic financial operational assessments we've done. That's been a recommendation 3 times. The reason being is that most organizations have figured out their expense structure. Board members understand dollars going out to the organization and tend to become the focus. What they don't understand often is the revenue coming in, whether it's in terms of volume or payment. And so, our focus in a process of a strategic financial operations assessment is really targeted on figuring out a way to grow volume. And frankly, there's not a rural hospital out there that can't grow volume, because on average, 70% of patients drive right by the front door outside of absent the emergency room for care. And that gives you opportunities. And then the second bucket again is payment. So those are the three kind of areas of focus in an assessment. Wade has already tipped his hat on, as we go into a strategic financial operational assessment process, what we're looking for is, he mentioned it, the three keys to the most successful organizations that we've run into. And I mentioned this on the webinar 2 weeks ago for those of you who participated in that. The first is this abundance mindset that Wade talked about. The second is a fundamental understanding of economics. And I'm going to get in and explain that, because even to this day, organizations, I don't know if they firmly grasp, or many organizations don't firmly grasp that. And then the third is a measurement culture. And so we've got the next couple of slides is all around how we look at improvement and what we focus on. So the first, I mean, this is our organization's values, and impact, interdependence, respect, and abundance. And they happen to be my personal values as well. But the one I've circled is an abundance mindset. This was something Stephen Covey in the 7 Habits of Highly Effective People 35 years ago coined. And if because I think this is the most important characteristic of these successful hospitals, I'm going to read a little bit about that. This is coming out of page 219 of that book that I just mentioned. Most people are deeply scripted in what I call the scarcity mentality. They see life as having only so much, as though there was only one pie out there. And if someone were to get a big piece of the pie, it would mean less for everybody else. And I'm going to paraphrase, me. People with scarcity mentality have a difficult time sharing recognition and credit, power, or profit, even with those who help in production. They have a hard time being genuinely happy for the success of other people, on and on and on. Often people with scarcity mentality harbor secret hopes that others might suffer misfortune, not terrible misfortune, but acceptable misfortune, putting them in their place. They want other people to be the way they want them to be. They often want to clone them, and they surround themselves with yes people, people who won't challenge them. So this is the 180 degree, the inverse of abundance is this scarcity. Abundance, it's just 2 sentences. The abundance mentality, again, page 219 going into 220, flows out of a deeper inner sense of personal worth and insecurity. It is the paradigm that there is plenty out there and enough to spare for everybody. It results in sharing the prestige of recognition of profits of decision making. It opens possibilities, options, alternatives, and creativity. That's what we have. That's the abundance mentality. We wanted to have Megan join us on this call because she's one of these abundance leaders that is so rare. We don't find them often. And one of the reasons is that a scarcity person who's out for themselves tend to focus our target, an abundance person who's out for all others. And again, so what we do is when we go on site, we tend to look for this abundance and encourage it. I was at a hospital recently where they got into some financial trouble, and that insecurity created a kind of a drift into scarcity mindset. And so the conversations I had with the CEO and leadership team was, okay, let's solve for this cash, but let's get back to abundance. And here's what that means. Let's create a growth-oriented approach. I look at abundance and growth is really one and the same. A scarcity person is going to have hyper focused on expenses. So number one, in a process of a strategic financial operational assessment, we look to highlight and bring out elements of abundance for the organization to become successful. All right, next slide, Wade. The second, and 2 years ago, the University of Iowa, it was Dr. Clint McKenney and Tim McBride, Keith Mueller, came out with an article on essentially looking at the variable cost of a rural hospital, comparing that variable cost to larger hospitals. And what they found was that the smaller the rural hospital, the lower the percent of variable costs to fixed costs. Why is this important? It's important because there's something called a contribution margin. Contribution margin is the revenue. Let's say it's the revenue of an inpatient day, and that's $2,500. The variable expense associated with it, if we close our eyes for not too long and think about that, in the smallest of hospitals is somewhere between 5% and 10%. So do we admit a patient today? If we do, we get paid $2,500. If and our costs are going to go up on average $250. That's a 90% contribution margin, and contribution margin goes to cover all expenses that are fixed or step fixed. Our financial statements will not give us this information. It really becomes an assumption. And so what this implies is that organizations that fundamentally understand this concept of contribution margin and how small variable costs are, immediately realize the opportunity in growth. I'll share a quick story. I was speaking at a conference last fall, and a CEO of a larger hospital, 200-bed hospital, came up to me and he said, "Eric, I'm losing money on every surgical case I provide. And so you can't make that up with volume," is what he said. He said, "The more volume I do, the more I lose." Unfortunately, I was in the middle of a tequila. I didn't want to get into it challenging, but what that highlighted to me was even in more sophisticated organizations, there's a misunderstanding around what true variable costs are and how contribution margin is the key. It's not fully allocated costs. I wish we could sit back and have a 30-minute conversation around this, because fundamentally understanding this concept with a abundance mindset leads an organization to kind of one conclusion, and it's this volume growth opportunity. So next slide, Wade. So what are some of these opportunities? And we often look at this, kind of efficiency. People always talk about efficiency. We want to become more efficient. And I look at efficiency, the number one way to improve efficiency when 90% of our costs on average are fixed or stepped, is to figure out how to grow volume, which dilutes this 90% cost bucket over more units of service. We do one more case, we just diluted our costs. We became more efficient. And so having appropriate patient volumes meeting the needs of the service area is absolute strategy number one. And it becomes the focus. Often we look at Medicare market share. We look at ER admissions, and ER admissions between acute and observation, maybe 6% in a hospital. Our target for rural is somewhere between 10 and 12%. The first conversation is, why aren't we closer to the benchmark of 10 to 12% of our ER visits result in admission than we are to the 6%? Opportunity for growth. The other area is kind of, this gets back to that second bucket that I talked about, was getting paid better for what we're doing. Revenue cycle practices, operating with best practices. I was at a hospital recently that really struggled with the revenue cycle, and cash was really drying up because of significant challenges in their revenue cycle practices. And so there was a whole process to get them back up and running and get cash coming in the door. Expenses managed aggressively. This is an interesting one, because I said it's that third bucket, but it's never becomes a focus of a strategic financial operational assessment, because it's not often where it's the Pareto rule of improvement. Doesn't fit within the 20% of effort that results in 80% of return. However, it doesn't mean, especially for critical access hospitals, we often hear, well, we're a critical access hospital, we don't have to manage our expenses aggressively. And I fundamentally disagree with that. And because any organization, your cost-based payer mix is your risk-free portfolio. The key is to manage expenses so that you can be profitable and efficient on your non-cost-based business, which generates profit. Your physician practices are managed effectively. Increasingly, as physicians and hospitals become one in the same organization, we've got to understand physician practice management. That becomes a target within a strategic financial operational assessment. And then effective organizational design. We're going to get into that in a few slides. But when efficiency is all of these things together. So where are the opportunities around growing patient volume? Again, checking the box in the three characteristics of successful hospitals of understanding economics, as we just talked about, incremental contribution margin to dilute fixed costs, and overall volume, the tide that lifts all boats. One of the biggest opportunities we come across, and this happened last week at one of the hospitals I was at, there was one department where every year volume was just going up and up and up. And I was sitting down with the senior team and I said, there's a pitcher in that department. And they kind of looked at me and said, what are you talking about here? Well, what I'm talking about, in using a baseball analogy, there's most 80, 90% of department managers are fundamentally pitchers. They sit behind the plate, and if the volume doesn't come in, they point at the doctor and say, they threw a wild pitch. They didn't send us any patients. And they sit behind the desk waiting for the volume to come in. Then you have the 10 or 15% of your managers that are pitchers. They're the Nolan Ryan 100-mile-an-hour fastball. They're out there, they're meeting with the physicians, they're presenting their new technologies that they have available, their new services. They're out leading the 5K runs. They're in the schools. They're out there. They make their schedule available so they can see patients over the lunch hour or they stay after. All of these are what we see is when you see a pitcher manager, you see growth. Each one of you, I challenge you to think through your managers and ask who's the pitchers and who's the catchers, and how do we create more of a pitcher culture in our organization? Number one opportunity to grow services. The other other opportunities, getting more targeted, kind of ER admissions, right? As I just mentioned, we like to see ER admissions for rural hospitals, admissions, either acute or observation, total between 10 and 12% of the admissions. We'd like to say, okay, you should be tracking that number as an organizational KPI. You should be tracking it by individual ER physician and hospitalist. So you'll see one doctor with a 12%, another with a 3% admission rate. But tracking that information kind of eliminates that variability. Swing bed services, it's a recommendation in 75% of our reports, because as soon as you shine a strategic importance spotlight on swing bed, it grows. As soon as you take it off, it shrinks. So how do we keep that light on our swing bed program as an organizational priority? Ancillary services, all types, imaging, lab, ER, all of these opportunities to take on more patients. Understanding market share. What is our market share? We always like to think, we start with the zip code that the hospital physically resides in. And we like to see inpatient market share, and we have Medicare data available, somewhere between 40 and 45%. Again, Medicare inpatient market share in the zip code that the hospital physically resides in between 40 and 45%. And then marketing strategies, clearly an opportunity to promote us. So all opportunities around volume growth. The revenue cycle. Amy could kind of talk story about this, but obviously getting paid better for what we're doing is huge. I always like to think that there's two fundamental focuses. If we get these right, we have better outcomes than not, and that is a measurement culture. We're going to talk about that in a minute. And the second is loading everything into the front end process. Increasingly, as we all know, the denial management is becoming core to effective management. Having our charge master, all of these are opportunities that we look for in a strategic financial operational assessment process. Next slide. One of the things, getting paid better, speaking of getting paid better for what you do, is when we're understanding our physician practices, do we have them in the right clinic designation? Especially for the critical access hospitals. Freestanding clinics, where you don't exclude your physician compensation, pull a lot of overhead down. So we always try, is there any way we can convert these clinics that are freestanding to either provider-based or provider-based rural health clinics? Now that the rate is $152, moving to $165 next year, it, for those of you who had looked at rural health clinic 3 or 4 years ago, and the rate was $100 and then grew to $113, now may be a time to reassess opportunities in rural health clinic. I always like to say, if we are freestanding, convert to a provider base, we have to add on another $35 to $45 per visit 340B pickup on the contracted retail pharmacy. So clinic designations, super opportunity for us all. Next slide. The last bucket, again, the 3 key characteristics of the most successful critical access hospitals: abundance mindset, understanding economics, and a measurement culture. This comes out of kind of organizational theory, where there's a 3-legged stool of decision rights, performance measurement, and compensation. And what happens is we any one of these 3, we have to compensate with the other 2. For example, decision making. One of the things in our rural hospitals is ultimately pushing decision making down to the frontline managers and care staff, because they have very site specific information difficult to transfer. And because of that, pushing decision making down is really important. Well, if we're going to put decision making down, then we should be rewarding them with compensation in line with the organizational goals. I'd like to see, kind of merit-based compensation over straight salary to recognize that. And the third leg of the stool is, if we're going to put decision-making down, if we're going to tweak compensation, then we better create a measurement system for 2 purposes. One is so the managers can see the outcome with measurement of the information they're using. And the second is you have the leaders of the organization see the results for parts of the organization that they do not have direct influence on because of the decision right changes. So measurement is important. I always look at an organization and say, performance measurement essentially takes politics out of decision making, driving accountability in. So where does some of that look like? What are some opportunities here? Next slide. So one of them is management accounting. I look at management accounting, and some of the best practices identified here on this slide as the core to getting measurement culture embedded in the organization. And you're going to say, yeah, Wade, you and Eric, Eric, you and Wade are both accountants. This is easy for you to say. But what I like to think of is management accounting where department managers are engaged in the annual budget, both volume and expense perspective. Often we see hospitals where the CFO holds the managers accountable for expenses, and then says you have no control over volume, so we'll take that one, which I fundamentally disagree with. So managers are involved in setting the budget. Then on a monthly basis, they have responsibility reports. There's often required variance analysis. And then the last piece is quarterly DOR, Department Operation Reviews, where the CEO, CFO, senior team can meet with the department managers to both share information and educate. And so this is number one opportunity that we see around getting measurement culture instilled in our organization. Next slide. Staffing efficiencies. I said we have to, it's never a focus of the Stroudwater Strategic Financial Operational Assessment, but that's not to say we don't look at staffing. This is an analysis of a hospital we did a couple of years ago. For each department, let me just showcase, for example, nursing, med-surg. The volume in 2020 for this hospital was 4,500 patient days. Patient days being defined as acute observation and swing bed. The standard that we look for is 12 paid hours, not work, paid hours per patient day, which would equate to 26 FTEs. This hospital had 34 FTEs. And you would say, Eric, wait, so if we look at obstetrics, they had an obstetrics program, they had nursery. Overall in the nursing, they're overstaffed by 13. Shouldn't we have a recommendation to cut staff? And our recommendation here was you can support growth in your swing bed program. You can support growth in your acute program, that growth piece, creating contribution margin because you have the staff to do it. And then you can look down through all the departments. Another key metric is emergency room. We like to look at 2.75 paid hours per ER visit. In this case, that would result in 10 FTEs. These guys were at about 15, so they're over a little bit. But that overage allows them to grow. So anyway, staffing. Here's another high level. I like to do this for an organization. I'd say I recommend you should do it once a quarter. I've had consultants come in and they told a hospital I was working with that they should benchmark their nursing productivity, to nursing staffing to volume every 4 hours. And as a critical access hospital, I just disagree with that. Next slide. Here's revenue cycle. This was something, gosh, I think I came across this 10 years ago in a critical access hospital in Indiana. I really like this because for each, they identified a set of KPIs, the responsible person, they have a benchmark, a target, and then they trend it over time. They used this template, this KPI dashboard to essentially establish revenue cycle, weekly revenue cycle team meetings from variance to target. They created a work plan around. So revenue cycle, measurement, opportunity. Next slide. Quality. Quality is a great opportunity for a measurement culture to be instilled. Again, taking politics out of decision-making, driving performance in. Again, this hospital, they established for each of the quality indicators, the patient satisfaction, the core measures, they had a goal, variance, actual target. They tracked it over time and used this to have the discussions in their monthly quality council meeting. Next. Provider complement. I always like to at least, kind of once a year, sit down, and there's been studies been done over the last 20 years that look at, given a defined population, so in this case, the hospital had 24,000 in their service area, what would we expect from a primary care? So this first column is the low end of the study, the 3 studies. The second column is the high end of the 3 studies. So what this is saying is that for a community of 24,000, we would expect somewhere between 16 and 21 primary care FTE providers. This hospital had 11, and the significant shortage. This tells me, again, that we're short on primary care, and likely people are leaving our community. What an opportunity. Next slide. And I just want to show you a couple case studies. This was a hospital that we did a strategic financial operational assessment on back in 2018, late 2018, right after a new CEO came in. This CEO was one of the top 5 most abundant CEOs, abundance mindset CEOs I have ever met in my entire life. Just a superstar. Now, it takes time for an abundance mindset and in growth. It's like an investment approach. It takes time to see the results. But the numbers here, total operating revenue is the dark blue. Operating expense is the red. And you can see when those two crossed, we started creating significant profit. Then the measure we like is EBITDA less debt service. That's the light blue. So they increased to 12%. Abundance focused CFO. Established relationship with medical staff, significantly improved revenue cycle functions, financial managers, all held accountable. The 3 characteristics, abundance, understanding economics, and measurement, were all instilled in this organization. Next slide. This was another case study. Relatively new CEO came in, redeveloped the program with an orthopedic provider, and significant growth. Very abundance mindset. Next slide. And then the last one I just want to share. This one was a fascinating organization. Absolute focus on becoming a blue zone community. So an investment in population health. Great top 5 abundance minded CEO, CFO that held people accountable for around measurement. And an absolute commitment to growth. And you can see the financial results here. Next slide. I believe I'm going to turn it. Okay. Yeah. So some of the findings, often we come in and we find this lack of measurement. And so a lot of our recommendations are around, again, where can we instill a measurement system? Example, the ones they just shared. Lack of market share data. They don't know that they're only 25% Medicare inpatient market share in their home zip code. Let's understand what that is, why we got there, and what do we have to do to improve. Non-existent strategic plans. I mean, today's age, when payment system, which affects everything that we do and how we look in doing it, is evolving, strategic plans are important, at least to look out for 3 years to say where we want to be. Revenue cycles, we talked a lot about that. And then productivity management opportunities, all opportunities that we focus on in looking for opportunities for rural hospitals. Next slide. So again, repeating again, key strategies, this abundance mindset, understanding basic economics, understanding contribution margin, and go take a look at that study on fixed and variable costs. If you don't have it, send me a note. I'll flip it to you. They're actually, I sat next to Keith Mueller today in a meeting from Iowa, and they're coming up with an updated version of that next week. So stay tuned for that. And then this measurement, this organizational design that promotes accountability through measurement. Wade, I think I'm going to turn it over to you.
Sure. No, I appreciate that overview, and it's good to get back to basics every now and then, to get back to the fundamentals, to really make sure that, as an organization, whoever's on here, be thinking about some of those key areas that Eric mentioned. Do we have an abundance mindset? Do we have that measurement culture? Maybe there's opportunity for us to get further education around the fundamental economics in a rural hospital and really use that to drive our performance improvement initiatives. Just want to speak briefly about the action planning process. So when we're working with the hospital and doing some performance improvement work, it's really important to have, as I mentioned at the very beginning, an actionable plan that comes out of it. So you're provided with all this information about, how your organization compares to rural hospital best practice. What are some good benchmarks that you can compare yourself to? And you've identified some areas of opportunity. So the key then is trying to figure out, how do we take that identified opportunity and actually see it result in realized opportunity. And so the action planning process is really essential to that. We feel having a good action planning process. This is just an example of an agenda that we put together. And really the goal here is to take all of the recommendations that come out of a strategic financial and operational assessment and start to prioritize those recommendations. What is most meaningful for your organization, and how can we develop those actionable plans? So again, this is not a meeting for the faint of heart. They're often very robust and engaging, and it really requires your full attention to get the most out of an action planning process, but it's well worth it in our experience. This is just an example again of how we've in the past prioritized recommendations that have been provided to rural hospitals, really with an ROI calculation as well. Again, we want to prioritize based on a number of factors, right? It's not purely financial, but financial impact is a component that we need to make sure we understand. And so this really helps in terms of prioritizing those action plans. And then once we've prioritized those action plans, here's again just an example of a developed action plan. So in this case, the action plan was to address care gaps in the clinics through things like annual wellness visits, chronic care management, a development of their CCM program, transitional care management, et cetera. So what was done is you identified the issue. So in this case, a lack of proactive outreach was resulting in a decrease in market share. So there was opportunity there, right? We got to stay growth focused and identify that opportunity. That's been done. Then you set a goal that, again, is rooted in data, right? So in this case, they chose to increase proactive patient clinic visits to 25% per clinic. So we have a number in there. We have something we can then benchmark to going forward. So really important to identify a goal that is specific and that we can measure against. And again, these are just the breakdown of the steps that took place after that goal was established to see how do we achieve that goal by the target date that was implemented here. So again, just one example. This is another example, which again outlines, in this case, they wanted to make cost report improvement opportunities, often a big area of opportunity when we work with rural hospitals. So again, going through those steps. What's the issue? We're not being reimbursed fully for our incurred costs. And then the goal was to optimize cost reporting to capture 80% of the identified opportunities throughout the engagement, right? So again, you go through the same process, develop steps that get us to achieve our goal by the target date that's developed. And then really having owners is another key part of this. We need to make sure that every action step has somebody who's going to be ultimately accountable to see that action step to fruition. And so very specific, very important to have those very specific elements to a good action plan, in our opinion. And the takeaways are really from, in order for action planning to be successful, it requires dedication. We need some maybe financial resources to see it through. We also need a lot of work from our human resources, right? The people in our organization. It requires an investment of their time. And so it's a process that requires dedication. It's also really important to have buy-in and accountability. I'm sure Eric can share more from his experience, but I know for me, when going into a hospital, if there's not support from the most senior level of the organization, it can make it really hard to develop something that's actually going to be actionable and that we're going to see, realized in the next few years or whatever our time frame is. And so I think really important to have that buy-in in the senior level of our organizations to see this through. And, sometimes we have to change the way we're thinking about things. As Eric mentioned with the abundance mindset, sometimes it takes a mind shift for us to realize opportunities because we need to reframe our mind around what we're trying to accomplish here. And so with that, we're going to have a discussion here, and I'm excited. We're going to hear from Megan Weber, the CEO at Scotland County Hospital, as Eric mentioned, a true abundance leader. And so we're going to jump on into this presentation. She's going to share a little bit more about her experience with this process.
Good afternoon, everyone. I'm Megan Weber. I became the CEO of Scotland County Hospital in August of 2022. I got very lucky. Our board had already engaged with Stroudwater, and Eric and Wade came on site my second week as CEO. So I was blessed to be able to do this action planning with them very early on, and it kind of probably jump-started my success very quickly, having them come in and do the action steps with us. The action planning is very objective, and I think that is what helped me the most. I will say, I think the biggest takeaway from Eric at that time for me was the abundance mindset. It isn't something that I knew much about, and Eric spoke of it, and I'm like, we have 8 days of cash. That's not very abundant. How do I get into this abundance mindset quickly? Because scarcity was kind of just throughout the hospital at the time. Our financial decline had happened over the few months prior to this. So it was a huge shift in mindset for not only me, but the other leaders that had been present at the hospital at the time. So I do think that if you don't know or haven't read about abundance mindset, read it this weekend, because it does really change the way you look at things. It's easy to get into that scarcity position when insurances aren't paying, your denials are up. So just getting into that mindset can help lead in a positive way. So you can go to the next slide, Wade. Our hospital is a critical access hospital in the very, very rural Northeast Missouri. Our service area is 4 counties. We're the main provider and family practice in the area. One of the great things that they provide in the SFOA is just understanding your service area. And that was huge for me at the beginning. I had been at the hospital for 12 years. I'm a physical therapist by trade. So I had been in the therapy role as a leader there at our hospital. So I knew the community and our patients, but really understanding what your service area looks like is a very helpful thing for strategic planning. So you can kind of see the very northeast corner there. We kind of bleed out into 4 counties. We do have 4 rural health clinics in those 4 counties. We're actually looking at adding a 5th rural health clinic in the next fiscal year. So we're excited about that. But our service area is, like I said, around 12,000 people. Next slide, Wade. So one of the things that was interesting for me to see was just the population. 56 of our percentage of our service area is younger than 45, which isn't something at the time. I remember thinking that was a surprising statistic for me. So really understanding that if you haven't had that study done is very helpful. Next slide. These aren't as pretty as the financial graphs that Eric showed a little earlier. This, you can kind of see the financial decline we had prior to 22. Our financial status, continued on a downward trend. Our revenue cycle was outsourced. Our EMR was very broken, and our cash continued to dwindle. You can see in the first graph, our revenue wasn't, covering our expenses. Our operating margin was tanking in 21. Like I said, the first day on the job, I learned what days cash on hand was very quickly, and we were very low. So the board made the administrative change in 22, right after the beginning of the fiscal year, and new CEO, new CFO, and we kind of really got lucky with them coming in to provide the action planning for us. You can go to the next slide. So looking back, really having the ownership with across the board with the leaders made the action planning successful. I would say we did have a couple leaders fall off, and I don't think we acted quick enough to get them in the action planning part when the leaders were replaced, but we are doing this same project with Stroudwater in the quality realm, and we definitely will be staying on top of the action plans each month. So those are just some comments I typed out for something from my perspective looking back on. But the action steps are objective. You can follow them. We set goals and dates for each goal, and it's just laid out in a way that it's easy to follow, even for a new CEO like myself who had never done such a massive project. It's just a great way to look about it. And we've actually used this setup in a smaller scale to do our own strategic plan. We had a board retreat last week, and we kind of used the same exact style of planning that Stroudwater implemented with us in 22. Let's talk a little bit about our action plans we set. One of the areas of opportunity for us was growing our swing bed and action plan 1, and we had another action plan that included our inpatient census. So they gave us a goal of our daily census to be 6.6 for our swing bed program, which we were able to meet from 23 to the projected end of this month, which for us, June 30 is the end of the fiscal year. We were able to increase our skilled days by over 15%. And then with improvements in revenue cycle as well, we were able to double our revenue, our net revenue in skilled. So we were able to have some success on the finance end and patient care. And we continue to focus on reaching out and growing our swing bed program. We were able to implement a hospitalist program. So we have rotating hospitalists, and that's really helped stabilize our hospital inpatient and acute and swing bed program. And then number 2, our hospital was very weak in measurement culture across the board, especially revenue cycle, where things really need to be focused in and measured. And we just were very weak in that area. So we were able to set the action plans for our revenue cycle. And then I made a little note here. We were at 90 days in AR on the hospital side and 213 days on the clinic side. And then by December of 24, 2 years later, our AR was down to 38 and our hospital, 38 days in the hospital, and our AR was down to 50 in the clinic. So we did, we still have a long ways to go in revenue cycle, and we actually just went live with a new EMR. So we're kind of back to building again, but because of these steps, I truly believe we were able to build up our cash. We hit 40 days of cash 2 years later, and because of that, we were able to go live with a new EMR. So by December of 24, our net contribution was 442,000. So we went from losing millions to improving and having, closer to a break even and profit. But like I said, we went live with a new EMR, so our end of year isn't looking as good as what we would want it to. And then action 4, we still are in the phases of getting that finalized. We're much closer. So that's taken a little bit longer of time, established the patient-centered medical home and RHCs. And then the cost report was a big one for us. We amended our cost report, and with the improvements there, in 22, we were able to amend and receive an extra $472,000 on our cost report. So that's been very helpful with our accounting processes and improving our cost report. Next slide. Here's just an example of the action plan that we use for the swing bed program. Like I said, we were able to improve our census to an average of 6.6. And then those were just the action steps that we took to do that. We're still doing those today. We're still reaching out. We have a case management team, a swing bed coordinator. That's her main job, and she talks to the hospitals and does a great job for us. So that that action plan was very successful for our hospital.
Megan, does that continue to be a strategic focus for the organization?
Yes.
So you never took that important spotlight off of it, off of the program. Yeah, good.
No. And it's just a great service for our community. We're so rural that, our patients have trouble traveling anyway. So getting them back home to recover is just one of the best services that we offer at our critical access hospital for sure. So is that the last slide?
And one of the things I do want to mention around Scotland County Hospital, they continue to offer obstetrics and in a rural environment where we're just seeing obstetrics programs being closed one after the next. Megan has been able to maintain the service in a community of only 12,000 people. And to the organization's credit, she has made that work.
We had just brought on a new full-time OBGYN, and we have a strong desire to keep our labor and delivery unit. We have very passionate providers, and we have a very strong will and abundance mindset to keep our OB alive.
One of the things that Megan kind of mentioned was that this was 2 years ago, almost 2.5 years ago, and cash was almost down to 0, and it's up to 40. And so, boy, you're like, why wasn't our cash at 100? And in this investment approach that we talked about, this abundance mindset and economics, was we can't cash. We're taking cash that we're earning and investing it back into programs to continue to accelerate this growth model. And
I think
yeah, go ahead.
I think you have to be patient. I mean, that's one of the strengths of having an abundance mindset. You can't be too greedy. We bought a new 3D mammogram. We were down with all capital. We have to upgrade our capital purchases, and our building needed upgrades. And we've kind of just done a balance over the last 2 years of upgrading all that stuff for, to strengthen our future. And that's one of the reasons our cash didn't climb as fast as it probably could have, but it was very needed for us.
But that's that investment approach that you guys have done so well at. And just like that case study one that I showed, where coming out of the blocks, growth was lower. And as the investment started to accumulate, the performance accelerated. And I would like to think that Scotland County is going to have a similar trajectory. So is that the last slide, Wade?
I think that's my last
so
slide.
We're all wrapped up. We there were a couple of questions though that we got. I don't know if you all want to take a couple minutes here. A lot of them are so Megan, getting a couple of questions on how many births per year. Right. for Scotland County?
We have been in the 80s. Our goal is to get back to the triple digits. I don't know what exact number we're going to be at the end of this month, but lower than 100 for sure over the last few years.
Yeah. Right.
Do you expect that to grow any, Megan, with the recruitment of the new OBGYN?
We haven't had a full-time OBGYN for over 2.5 years. 3 years in August will be the last time we had a full-time OBGYN, and she's been awesome, a great addition. We have a large Mennonite population in our county, and she's done well with the outreach to them. And I'm confident that our numbers will grow with her here.
Another question from David Waltz around great results. Congrats. Given your cash position, what kind of reserves did you have?
Not much.
Yeah, I mean, I think a reserve did you have a line of credit? I think at the time,
We still don't have a line of credit.
yeah, the banks were not willing to give us a line of
I
credit.
I will tell you, we had our local electric co-op, 2 of them gave us a $1.2 million loan that's interest free, and we didn't have to pay for 2 years. So that helped us with our EMR transition for sure, and the increased costs. It was through the USDA and the Red Leg program. So that was a huge help to us with our local electric co-op. And we are an independent critical access hospital. We went with Meditech Expanse.
The question that came through was, what EMR do you use?
Yeah, she just answered it.
She
What
is.
was your, Amy or Megan, what was your thought process around the Meditech Expanse?
We were already on Meditech. Our original EMR that we went live with in 2014, we were on Meditech 6.08. So a lot of the processes were kind of similar, and they really did work with us on cost, on pricing.
That's great. Any other thoughts or questions? Amy, why don't we turn it back over to you?
All right. Hey, thanks, Eric, Wade, and Megan, just for highlighting the value of independent insight in building a stronger, more resilient hospital. We are now going to shift over to our final session in this conference, which will focus on a core pillar of long-term success, your provider strategy. So what's going to happen is we are going to close out this session. If you wait, your Zoom will refresh, and then you can join that session. So I look forward to seeing you over there here shortly. But thank you all very much again, Megan, Wade, and Eric, for your time today. Eric, I appreciate the shout out for Revenue Cycle, so I heard that too. But do look forward to chatting with you all for our attendees over in this next session.
Thanks, everybody. Have a great afternoon.